Thank you so much for the introduction. So thank you for the invitation and for this very, very kind introduction. Bonjour. Je peux parler en français, mais parce que j'ai passé un an à Bichat many years ago. But I was instructed to give this lecture in English, so I continue in English. First of all, I want to mention that I have no financial conflicts of interest regarding this topic. You may know the most recent definition of patient blood management, which was published 1 year ago in September 2020 in Anesthesia by the group of Shander. And patient blood management is defined as a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving the patient own blood while promoting patient safety and empowerment. And also involves multidisciplinary application of evidence-based medical and surgical concepts aiming of detecting and treating anemia, decreasing perioperative bleeding and medical bleeding and coagulopathic bleeding, and also supporting the patient while appropriate treatment is initiated. I read all this because I wanted to stress, to highlight that it's nothing related to transfusion in this definition. However, when I started to be interested in this concept, at that time it was called the blood conservation, in fact. This was the father of the concept of patient blood management. I was interested in optimizing the blood usage because in Romania, at least, we had shortages of blood products. Romania at the time had a low position, you see, regarding donation, and it's better now, but it will be not be much improved because all over the world, as you see in the figure here, the donation is decreasing. We also have to know that in Eastern Europe, we know this from ICON studies of Jean-Louis Vincent, in Eastern Europe, we use more blood than in all other regions in the world. So we have a problem. And together with colleagues from other specialties, nephrologists, surgeons, cardiologists, gastroenterologists, we drafted some recommendations for perioperative period for patient blood management in Romania, and we published in our journal a couple of years ago. And these recommendations are simple, but based on the European Society of Anesthesiology and Intensive Care guidelines. And these 10 recommendations are to set up a hospital patient blood management implementation group, to plan better the surgical intervention, to assess anemia and iron deficiency, optimize patient red cell mass, assessing for hemostatic abnormalities, minimizing iatrogenic blood loss, implementing a protocol for acute hemorrhage management, optimizing tolerance of anemia, restrictive transfusion protocols, and monitoring the program. We were fortunate because the Minister of Health endorsed these recommendations and published in the official journal of Romania, where all the laws are published, and became national recommendation of patient blood management. And this was done with the help and very strong advocacy from the Romanian Society of Anesthesia and Intensive Care. We also succeeded to convince the Minister of Health and the National Insurance House to reimburse the preoperative ambulatory treatment of anemia, and this is covering the consultation, the cost of some lab tests, and also 0.5 gram of IV iron. We couldn't do more at that moment. And also, we stressed in the national guidelines for patient safety in anesthesia and intensive care published in 2019, which are in line with the WHO, WFSA standards for safe anesthesia published a couple of years ago. We stressed the need of preoperative evaluation of patients at least 7 days before elective surgery, which is not done in Romania. I will show you later. We also succeeded to get some more financial support for intensive care patients, and these patients received more funds. We are receiving as hospital more funds for intensive care patients, more than is given by the National Insurance House. So we have the recommendation, we have the means, we have some funds, so we wanted to know what is happening with our recommendation in the country. Do our colleagues implemented them in the hospital? And we started to ask with a questionnaire sent to all members of the society, but also non-members. This survey was performed this year. We sent the questionnaire, 38 questions were drafted to 1,200 anesthesiologists, and we received a lot of answers. Around 500 started the questionnaire, but 300 fully completed the questionnaire, maybe less those questions on demographic topics. But as you can see, 54 of respondents were senior consultants working in public hospitals. Many of them are coming, 40% from academic hospitals, working in general orthopedic and obstetric environments, and 30% of replies came from Bucharest, but also from big centers, academic centers such as Timișoara, Iași, Târgu Mureș, Cluj. And it was quite encouraging that 74 of these respondents say that they apply patient blood management measures in their daily practice, and 97 confirm that PBM is useful to improve the outcome of surgical patients. They learned about this mainly from our congresses and scientific events, and also from our recommendations and guidelines of the Minister of Health. And also they organize in their hospital events. And it was nice to see that 33 have already, of those who answered, have in their hospital a patient PBM implementation group, and in most cases the leader was an anesthesiologist. But when it came to the pre-anesthetic consultation, we see that only less than 10% are doing this pre-anesthetic consultation more than 7 days, than 1 week. And in fact, 40% already almost perform this in the week before. So the patient is seen less than 7 days before the elective surgery. And going further, in fact, 48% of anesthesiologists see the patients, or the patients are seen 1 day before surgery, and still almost 30% see the patients are seen the day of the operation, although I showed you we have regulation for this. However, we ask if it's possible to treat on an outpatient form anemia in the hospitals, and 31 said yes, but regarding the tests available in their institution, you see that only 28% had the possibility to measure transferrin saturation, for example. many of them, 47%, said that they have an internal procedure for the treatment of preoperative anemia, and they have access to IV iron, you see 72%. But when we ask about the treatment of anemia in the preoperative period, only less than 30% treated, usually anemia in the preoperative period, a little bit more in the postoperative period. Regarding the management of perioperative bleeding, 53 declared that they have a written protocol for management of acute surgical bleeding, but most of them rely on standard coagulation tests and clinical experience. The use of tranexamic acid is high, but less than expected, and I was surprised to see that 40% have access to clotting factors concentrates, which are expensive in our country. But many of them said that they never used a cell saver or closed the collection of blood devices. When we ask about the hemoglobin threshold for transfusion, you see that for those with intraoperative bleeding over 65 years old without cardiac pathology, most of them choose to, as a threshold, 7 or 8 grams per deciliter. If the patients were having also a cardiac pathology, they went higher a little bit, 8 to 9 grams. If the patient were younger than 65, but still with intraoperative bleeding, you see that there are some going lower to 6 grams, but not so many. And also in those with known cardiac pathology, there are some going a little bit lower than usual. In fact, this is in line with our European guidelines on management of the perioperative bleeding available at that time. Now we have the new edition published this year, where we recommended in these guidelines a target hemoglobin concentration of 7 to 9 grams per deciliter during active bleeding. When we ask about patients without bleeding, being anemic, without cardiac pathology, you see that the pattern is almost similar. So most will choose 7 or 8 grams per deciliter. For those with cardiac pathology, a little higher. And in those younger, they are going lower, more than in those with bleeding. But anyway, the pattern is in the same direction. And in fact, this is could be explained by the fact that we do not have enough data to support transfusion in patients without anemic and without bleeding. We we recommend restrictive transfusion in general, but you have to know that we have mathematical simulations showing that if the patient is bleeding less than 60% of the whole blood, there is no increase in oxygen delivery. And this simulation showed that transfusion of any number of units lowers, in fact, the oxygen delivery to the microcirculation when treated up to 60% of hemoglobin losses. After 60, yes, there is an increase of oxygen delivery. We also asked about the barriers to implement patient blood management in their hospitals, and the main barriers were the short preoperative time before the surgery to see the patient and manage the patient, the difficult cooperation with the surgeon in the preoperative period, and also lack of organizational framework and lack of procedures. We also had some open questions, and we got a lot of answers. I tried to extract the most important ones, so everybody is agreeing that we need to implement this pre-anesthesia consultation more than 1 week before, but we have a big step to do from the day before to 1, 2 or more weeks. We need more collaboration with surgeons, so we have to educate them. We need a lot of infrastructure, and we need also to change the culture, and also to make audits and report this data. And these results are in line with the Hoffman results. We interviewed in 12 countries all over the world PBM implementers, and you see in other parts of the world also the lack of interdisciplinary commitment and even low awareness are important as barriers for patient blood management implementation. But there are some accelerators we have to take into account, and we try to do this. We have to generate data and to publish them, and we have to highlight the outcome of the patients. And we started to do this audits in our cardiac surgery environment, because I'm working in cardiac anesthesia. And we performed these audits in 2017, 18, and then in 2020. And I will present only some data which were important for us. We saw that patients with anemia receive more blood transfusion, what is in red. But also, we saw that these patients with anemia receive more fresh frozen plasma. More patients are transfused with fresh frozen plasma. And in this analysis of 7 and 10 patients, all are retrospective studies, we saw that we have some predictors of perioperative red blood transfusion, which are well known: female sex, hospital stay, preoperative anemia, but the fresh frozen plasma used in our environment is a risk for red blood transfusion. And also, you see at the right that the hemoglobin is a lot decreasing during the perioperative period, so intraoperatively. So this data suggests that we have a lot of work to do in our cardiac surgery environment for hemostasis, not only for implementing the treatment of preoperative anemia. We compared this data from 2017 and then 18 with another group of patients, with the patients operated in 2020. It's not the best comparison because it was a pandemic year and much less operation. Anyway, and we also do a matching, a constant matching, exact matching between the groups to look for some factors. And we were deceived in a way that we didn't decrease the rate of red blood transfusion, although it was a decrease, but not it was not significant. Patients in the after implementation of recommendations left the hospital with, they had in the postoperative period and left the hospital with a lower hemoglobin, but still the transfusion rate of red blood cells was the same. What was important was the decrease of fresh frozen plasma, because we had a high rate, and this is important, and also the fact that we used more standardized hemostasis questionnaire in this period after implementation of the recommendations, and this was also associated having more standardized questionnaire about hemostasis performed in the preoperative period was associated with lower transfusion of red blood cells. So good and bad, I do not say bad, but less than expected results. it's a retrospective analysis, not so many patients. We don't have 1 million of patients as presented in Germany, but we learn a lot of this data, and we look further in deeper in this data, and these are some unpublished data, and we saw that between the two departments in our hospital there are big differences. So I suspect that working closer with our colleagues and implementing at our home better our recommendation will give some better results in the future. So for every kind of blood product, there is a difference between the two departments, although the rotem use is the same, for example. So we need to change the mentality. It's so difficult when the blood is not paid in Romania. It's for free, so it's so easy to order, plasma or cryoprecipitate instead of other products and red blood cells. And even if the patients are anemic in the preoperative period, the surgeons usually do not agree to postpone even nowadays. So I think that, I hope that with the transfusion registry, which will start in Europe, as Kai Zaharovsky, who is the project coordinator, announced recently in Brussels, I hope that will increase the awareness of the importance of patient blood management and will improve the implementation in Romania. Because we have rules, but we have also a rule to be implemented should have some consequences or some norms. What is happening if you don't do this? And this was the mistake of our national and endorsed by Minister of Health recommendation. There is no punishment if you don't do what is written there. So, merci pour votre attention, et je vous attends à Singapore next year in March. Why? Because we have plenty of sessions on PBM. We will launch a perioperative PBM course, and I hope we'll submit to all member societies a declaration, the Santa Cruz Declaration, because it was launched last year there, on patient blood management, and I hope that the member societies will agree to sign this declaration, which is in line with the brief the calling from the WHO to implement, that it's urgent to implement patient blood management in all countries. Thank you.